Ladies and gentlemen, thank you for standing by and welcome to the Meaningful Consumer Engagement webinar on member meeting conference call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. If you should require assistance on today's call, or wish to ask a question, please press *0. I would now like to turn the call over to your host, Jessica Daniels. Go ahead, please.
Thank you, Operator. Good afternoon. My name is Jessica Daniels, and I work at the Lewin Group out of Falls Church, Virginia. Thank you for joining us for the Meaningful Consumer Engagement webinar series and today's webinar on member meetings. This webinar is the second webinar presented in conjunction with Community Catalyst in the Lewin Group and supported through the Medicare-Medicaid Coordination Office, MMCO, in the Centers for Medicare and Medicaid Services, CMS. Community Catalyst is a national nonprofit health advocacy organization that works with consumer advocates in over 40 states to bring the consumer voice to decisions affecting their health care. The Lewin Group is a healthcare policy and research consulting organization that has worked extensively with governments, provider organizations, and subject matter experts to support Medicare, Medicaid eligible, and MME beneficiaries and other high-risk populations. Together with CMS, we support providers in their efforts to deliver more integrated, coordinated care to MME beneficiaries. To learn more about current efforts and resources, please visit resourcesforintegratedcare.com. First, I'd like to introduce to you our platform for this presentation. Again, all microphones will be muted during this session. If your slides are not advancing, please push F5 on your computer keyboard. Also, please note the icon circled at the bottom of the screen. The icon with the CC will enable closed captioning. The brown icon will open a group chat window for participants to discuss any topic-related questions with other participants. After the presentation, we will begin the Q&A. Questions can be asked through the red question and answer icon or over the open phone line through the operator. We will select a handful of questions to answer. All other Q&A will be posted to the Resources for Integrated Care website. Additionally, on the Resources for Integrated Care website, you can find the presentation and post-recording within the Consumer Engagement webinar pages. The presentation is currently available for download, and the post-recording will be available next week. At the conclusion of the presentation, we will ask you to complete a quick survey of the webinar. Please take the time to complete this. We review all answers to make future webinars a greater success. Please contact rick@lewin.com, which is RIC@LEWIN.com, if you have any questions or additional comments. So at this time, I'd like to introduce our two speakers. William Dean, Delivery Service and Consumer Engagement Manager at Community Catalyst. As part of Community Catalyst's Voices for Better Health team, William builds collaborative working relationships with delivery systems serving vulnerable populations. Through the Meaningful Consumer Engagement Toolkit he's developed, William provides technical assistance to delivery systems, providers, and consumer advocates as they work together to elicit input from consumers, caregivers, and the community. A lawyer and former geriatric social worker, William previously led the Subcommittee on Aging and Long-Term Care for the California State Senate, where he staffed legislation and conducted oversight and informational hearings. Courtney Mulroy, Commonwealth Care Alliance. At Commonwealth Care Alliance, Courtney works to develop and improve CCA's ability to engage and integrate the consumer voice as a tool for change and improvement. Courtney has coordinated and facilitated consumer health workshops, member meetings, focus groups, consumer surveys, and is currently working to develop a consumer ambassador group. Courtney graduated from the School of Public Health at University of Massachusetts Amherst, has a certificate in public policy and administration, and is a certified Alzheimer's support group moderator. Now at this time, I'd like to hand the webinar over to William Dean from Community Catalyst, who will introduce consumer engagement and member meetings. William?
Thank you, Jessica, and welcome to everyone joining us today for our second webinar about meaningful consumer engagement. Let's go ahead and walk through the agenda for today's discussion. So I'm going to spend a few minutes recapping some key takeaways from last week about how we at Community Catalyst define meaningful consumer engagement. We'll take another quick look at the ladder of engagement, then I'll review some of the critical components of consumer engagement before giving an overview of member meetings. At that point, I'll hand it over to our expert panelist today, Courtney Mulroy. Following her presentation, we'll have a few polls that we hope you'll take to help us understand you a little better before ending with a question and answer period. As you may recall, we at Community Catalyst believe that engaging consumers in meaningful ways yields many benefits, both to the consumers themselves and to the entire healthcare delivery system. As delivery systems learn more and more about their consumers and caregivers, both as individuals and as members of a community, whether it be the senior community, the disability community, the LGBT community, or communities of color, the more quickly and effectively they can adjust their policies and fine-tune how they deliver care. Some of the care delivery improvements that I've seen as I've been researching for our toolkit that were the direct result of engaging consumers include increasing participation among Latino seniors in a walking club, improving members' understanding of how to use their care manager or their independent living long-term services and supports coordinator, which is an integral part of the Massachusetts demonstration, and streamlining the authorization process for durable medical equipment for members with chronic conditions. These and so many other examples tell the real story about the tremendous value that consumers bring to the delivery systems as they think about how to improve care delivery, especially to vulnerable populations. For more information as well as sample templates for different consumer engagement strategies, please consult our Meaningful Consumer Engagement Toolkit on our website at communitycatalyst.org/meaningful-consumer-engagement. These tools are designed to help health plans, health homes, and provider groups to work together with community advocates and, most importantly, consumers and their caregivers in an active and ongoing dialogue. If you were on last week's webinar, you heard me talk about the ladder of engagement, so I'm just going to recap a couple of key takeaways from that. First, delivery systems doing the best consumer engagement work, and as a result yielding the most effective changes and efficiencies to how they do business, are generally employing not one, but several of these strategies. Using different strategies, you're able to get input from different consumers who may or may not who may be more likely to participate in one type of engagement over another. This will help you achieve the diversity you're looking for. The other key takeaway has to do with how the lower level engagement strategies, the ones on your left, like newsletters and surveys, and the mid-level strategies, like focus groups and member meetings, are good ways to identify members you can reach out to for higher levels of engagement, like advisory committees and governing board participation. As you plan and start implementing your consumer engagement strategies, remember these key components. First and foremost, of course, is recruitment. It's important to cast your net far and wide if you're going to attract the diverse and rich feedback you're looking for. Again, using different strategies along the ladder of engagement will bring many different voices to the various tables you set. So don't pigeonhole yourself into using one approach. Use several. Initial and ongoing training, as well as support in the way of mentoring and accommodations to increase accessibility, are especially critical to consumers who wish to participate but just need a little help. And finally, develop a feedback loop. It tells consumers and their caregivers who've invested their time with you that their ideas really matter, even if some input doesn't result in immediate change. Today's webinar walks you through town hall-style member meetings, which are different from consumer advisory committees in that they bring together different groups of consumers on a periodic basis rather than the same consumers on a regular basis. Generally, member meetings take place in the communities where members live. This may be at a community center, a primary care site, or within congregate housing for seniors and adults with disabilities. The location options are endless, really, as long as they're convenient, accessible, and comfortable for members to sit and talk to you for an hour or two. These meetings can be both an opportunity for consumer input as well as consumer education, as Courtney Mulroy will give you some great examples of both of these. Member meetings can also help you recruit consumers to your advisory committees, since you'll have an opportunity to witness firsthand how articulate and compassionate particular consumers or caregivers are about improving care delivery. diversity of engagement is also achieved more readily. Since not everyone will want to or be able to participate in an advisory committee, member meetings may be the one chance you get to hear from certain consumers. Finally, member meetings produce consumer feedback that can be reported to your Consumer Advisory Committee or to your governing board for more careful analysis of whether there's a systemic problem and a corresponding solution. As with all consumer engagement, it's important to continually assess for absent voices to ensure that you're experiencing the full spectrum of input that's possible from such a diverse population of unique individuals. I emphasize this last point because while there are some benefits to grouping folks together as a way to engage them and identify trends, we can't forget that each and every member brings a unique story, a unique set of preferences and healthcare needs to the delivery system. So with that, I'd like to turn it over to Courtney to tell us about how Commonwealth Care Alliance uses member meetings to drive improvements and to connect with consumers, caregivers, and the communities they serve.
Great. Thank you, Bill. I appreciate the opportunity to discuss member meetings with you all today. And I'd like to start out with a brief description of Commonwealth Care Alliance. And throughout the presentation, I'll be referring to Commonwealth Care Alliance as CCA. So CCA is a not-for-profit, consumer-governed prepaid healthcare delivery system that specializes in care for dually eligible residents in Massachusetts with complex needs. The organization is a hybrid of both the care delivery and payer roles and is an accountable care organization prototype. CCA was founded in 2003 to administer the first dual demonstration program in the country for individuals over 65 called the Senior Care Options Plan, or SCO. CCA SCO serves approximately 6,000 members in Massachusetts, 75% of whom meet the criteria for nursing home placement, yet continue to live in the community. Our 10 years of experience with SCO positioned us to become an integrated care organization, which we call OneCare. As our second demonstration program, OneCare was launched in October of 2013 and currently serves over 7,000 dually eligible residents who are between the ages of 21 and 65 living with chronic illnesses and disabilities. 70% of this group has a behavioral health diagnosis. Consumer engagement has been a primary value for CCA since its inception in 2003. Our corporate founders are nonprofit consumer advocacy organizations that carry out consumer interests as their primary goal in assessing and advocating for culturally competent, accessible, and equitable healthcare delivery and policy. CCA's roots and current relationship with these organizations as board members and authors of our bylaws really speaks to our commitment to provide consumer-centered care and to promote consumer involvement as a central role to our mission and in our daily operations. And CCA does have the highest quality rating given by CMS to any SCO program at 4.5 stars, and we truly do believe that this is in part due to the central role that consumer involvement plays in our programs. Today we'll be discussing my favorite mode of consumer involvement, which are the member meetings. For CCA, member meetings are arguably the most established mode in which we carry out consumer engagement, other than the individualized care planning that our clinicians do. We've been running these meetings since 2005, and our president, Bob Master, this is kind of his brainchild. He likes to say during meetings that member meetings tangibly represent CCA's commitment to connect empowered, community-based primary care teams to self-directed members in the management of chronic illness and increasingly enhance the ability of the community to shape the care that it needs. So this truly is a town hall style meeting that we host, and we invite our members, their families, their caregivers to gather and share their experiences and opinions, providing direct feedback to CCA about the care they receive. Each member meeting also gives us an in-person opportunity to provide new information and educational resources to our consumers. This is a fabulous way of facilitating a direct forum for two-way information flow. CCA uses the information gathered at member meetings to identify trends in services and complaints, and on the other hand, the meetings allow for CCA to discuss relevant topics to that service area. Topics that we have brought to our member meetings include flu shot information, appropriate utilization of the emergency room, information about upcoming educational opportunities, such as the chronic disease self-management program that we run, updates to food stamps, changes in benefits, So really a wide variety of topics that we hope consumers will be useful. Next slide, please. We've run over 114 meetings to date, all of which have been coordinated and facilitated by CCA staff and occasionally a community partner. We use a community partner to co-facilitate just a handful of times, and that's been when we don't have the staff available who speak the language of the member group. I know a couple of years back we really wanted to engage our Vietnamese-speaking population in the Dorchester area of Boston, so we worked with the facility staff where the meeting was hosted to help co-facilitate because we had only had one staff member at that time who spoke Vietnamese, and she was not available. The meetings, again, are always run in the preferred language of participants, and occasionally we'll run a bilingual meeting if the member group has two equally dominant languages. As you can see on this slide, we've run most of our meetings in Spanish, as that reflects the most commonly spoken language of our population. We hope to increase the number of meetings in the other languages you see on the slide, and we just hired new staff to reflect that goal. This year we'll also be adding French Creole to this list. And something to note here, I didn't put it on the slide, but the number of attendees at each meeting really ranges depending on the concentration of members and the geographical location of the meeting, and also how many past meetings we've hosted in that area. The more meetings we have in an area, the more popular they become as word spreads. And so, starting out, sometimes we only have 5 to 10 members, but in more established sites, we've had to hold 2 meetings in one day, each with 35 to 40 participants. So they do become more popular as time goes on. Next slide, please. Oh, meeting format. So again, the member meetings are run in the communities of our members, like Bill mentioned, which is really imperative both to the success of the meeting, the attendance, and also in displaying importance of the member input to participants. Again, they're delivered in the language of the members, and on top of that, all documents are reviewed for cultural appropriateness. There's typically one facilitator, and the meetings last 90 minutes in full. About 20 minutes of that time is set aside for socialization and casual discussion, and I'm going to talk a little bit more about why that's so important in a few slides. We always provide transportation both ways, door to door, and we're sure to advertise that when recruiting for the meeting. On all of our printed flyers in big bold letters, it states that transportation is provided free of charge. We always provide healthy refreshments as well as giveaways to make the meeting more attractive to potential attendees as well. Next slide. Okay, so when we're planning the meeting, it's really important for us to choose a realistic time for the members to attend. So when we first started out, we did individual interviews with some of our consumers. We mailed a survey, really looking to find out the preferred time to host these meetings. And of course, that's going to vary depending on service area. Sometimes now we vary our meetings if there's a large target population in a certain area, so that there's both a morning meeting and an afternoon meeting to choose from. Location is also imperative to the success of the meeting. We choose a familiar location to the community, one that is ADA compliant, and if your health plan is not providing transportation, a location near public transit if possible, somewhere with a parking lot, or somewhere that has sidewalks is ideal. After we have the time and the location of the meeting set with the facility staff, the largest part of the planning can begin, and it's all of our favorite. It's the biggest beast of this, and that's recruitment. As difficult as recruitment is, we have found that our multifaceted recruitment strategy is most effective when outreach approaches are used in conjunction with one another. Before actual recruitment, we first pull a list of eligible members who live within a certain vicinity of the meeting location. And this spreadsheet includes names, phone numbers, the address, their care manager, their spoken language, a lot of demographics about the target population. For our SCO members who are over 65, we found that they generally don't utilize computers or internet that frequently. So we send a descriptive invitation and colorful flyer via the mail as a first step, and that's proven to be very successful. The invitation states what a member meeting is, why we host them, how member feedback is used to influence the quality of services, what to expect at the meeting, the time and location, and a method to get in touch with the coordinator to RSVP. The invitation also makes it clear that we encourage members to come with a family member or caregiver if they have someone there. This request is really mutually beneficial because caregiver feedback to us is just as important to improving our services, and it also helps those members who may be hesitant to come to the meeting alone. The invitation has a lot of detail, but that's so the members really feel comfortable with their expectations and understand that their feedback does really influence CCA's decisions, and this isn't a meeting in vain. The invitation, all of the content, is written at a 6th grade level, and it's electronically signed by our CEO, and this really makes the meetings as enticing as they can possibly be, at least on paper. The flyer attached to that invitation that we mail out is really colorful. It has very few words, and it has at least 1 or 2 big photos on it. The flyer serves to appeal to members who process visual images better than text, to members who may not want to read all the information in the invitation, and also for those members who perhaps can't read that well. Both of these documents are translated into the language in which the member meeting is held, and we mail the invitation and flyer together approximately 2 to 3 weeks before the meeting, and we make a follow-up phone call to every invitee to answer questions, get an RSVP, to ask if they need any special accommodations, and to ask if they would like transportation provided. And when we make that follow-up phone call, it's usually 2 or 3 business days after we've sent the invitation and flyer, and that flyer really serves as a reference point for the phone call. So, for example, when I give a call after sending these flyers, I say, "Hi, can I speak to Mrs. Smith? This is Courtney calling from Commonwealth Care Alliance, your Senior Care Options Plan. I was calling because I sent a flyer to your house about a week and a half ago. Did you see something in the mail from us?" And they'll say yes or no, but at least this is a starting point so the person on the other line doesn't think you're calling to sell them something. Sometimes I mention I work with the name of their care manager, so really just a point for them to feel comfortable and know that I'm actually calling from their health plan, and they can also use that flyer right in front of them as we're talking so they have the visual image. We also make a second follow-up phone call to all of those members that we missed in the first round of phone calls, whether it's because we left a voicemail and they did not call back, or maybe they don't have a voice answering machine. On top of the direct mailing and phone calls, we advertise the member meeting in our newsletter, and depending on our relationship with the facility where the meeting is held, we sometimes ask facility staff to mention the meeting and hand out the flyer to CCA members when they come in for an appointment, or if it's a community center, if they happen to be there that day. And having a relationship with the staff at these sites really enables us to leverage the familiarity that they have with our members. It's a very strong recruitment tactic. Lastly, whenever we have a meeting, we make sure that our primary care nurses in that area are aware of the meeting and can help to promote during their home visits. So we send an email to all of the clinicians in that area, and we let them know the details of the meeting. So in the event that a patient asks them, I got this invitation from CCA, do you know anything about it? So if the clinician says, I have no idea, that must not be from us, that's really going to deter our numbers in attendance, versus a clinician saying, oh yeah, that's our health education department. They hold these meetings. They're very, very valuable feedback. I really hope you can attend. So again, having that connection and having the members receive an invitation from someone they know and trust, like a nurse care manager, is much more powerful than, Jane Doe calling from the health plan to invite them. So using all of these recruitment methods in conjunction with one another usually allows us to get an average of 30 to 35 members, including families and caregivers, to each meeting. And again, that does, depend on how long we've been running them in the service area and the concentration of members. And to give you a sense of the resources that we're working with to implement member meetings here at CCA, the department that coordinates them only had 3 staff members up until a year and a half ago, and only one of these staff members designates about 50% of their time to member meetings. This coordinator relies heavily on internal volunteers and other team members to take on some of the work that goes into hosting a member meeting. The budget for each meeting is planned at the beginning of the year, and we usually spend around $50 on refreshments per meeting, plan for transportation costs for about 25 participants, and spend about $1 to $5 per participant in giveaways, such as stress balls, water bottles, CCA reusable bags, kind of fun things like that. Next slide, please. So the agenda structure is pretty standard for each meeting at this point. Of course, when we were first starting out, it varied. But at this point, we really start out always with the sign-in, a little time for socialization and refreshments, and then the first 25 minutes of the meeting are set aside for each member to introduce their name. They also are asked to say one thing that's working well for them and one thing that they would like to see improved as it relates to CCA, their services, or their contracted providers. And because this is the first agenda item, it really sets the tone for the group to feel comfortable to voice their opinions, and it also allows for a sense of connection among participants, knowing that others in the room are having a similar experience. So it's a great way to start the meeting. During the next 25 minutes, we discuss items that members have identified as areas they would like to address or that they would like for CCA to discuss. We ask them about their ideas for the agenda prior to the meeting, during our recruitment phone calls, or we reuse subjects from other meetings that members have brought up. For example, we've had members who wanted to discuss transportation services recently and why they had changed. So we talked about our new contract with a third-party transportation service, how that should affect them, and how to submit a complaint if it was not working well for them. Another topic members have set as agenda items is they were really curious about the criteria for obtaining a personal care assistant in Massachusetts. So we discussed what a PCA was, their role within our primary care teams, and how our care managers decide with the member if that service is or is not a good fit for them. The last 20 minutes of the agenda are for CCA to discuss topics which have been set by internal staff. The member meeting coordinator requests topics 3 weeks in advance from all internal departments. For example, last year, our quality department wanted us to explain what the CAP survey was to all of our members during the member meeting. They wanted us to tell them what the CAP survey was, why we send it, or that we don't send it out, but it's something that if they receive, it's very important to filling out honestly and giving feedback so that CCA can know how they're doing. And that was really helpful because a lot of members stood up and said, hey, I thought this was a scam, or I had no idea what this was talking about. So that was quality. And then recently our claims department had mentioned that a certain primary care site location had a really high utilization of the emergency room. So when we went to host a meeting in that service area, it prompted us to discuss the difference between using the emergency room, calling the nurse care manager about an urgent matter, and going to your primary care doctor. We also use these last 20 minutes as a time to announce upcoming events and opportunities, as well as changes that may have been made to the plan. The meeting concludes with more social mingling. At least 10 minutes in the beginning of the meeting and 10 minutes at the end are set aside for socialization. And it's really an imperative aspect in keeping the members coming back to meetings. It allows for time to create relationships, to establish a comfortable environment. It builds a sense of community. And, you know, by the third or fourth meeting in the same service area that we started running, we were seeing members greeting each other with a hug and a kiss on the cheek and asking about friends. And it's really just a wonderful thing that that these member meetings really do significantly contribute to the feeling of community in that area. And that social time doesn't only benefit the participants, but it's a really powerful tool for incentivizing members to come back, but also it's really an incentive and also a tool for retention. So next time they come or they're invited to come, they're going to say, oh, I had a blast last meeting. I'm certainly going to go to the next one. And just as a note, that any agenda should really allow for members to have the floor for at least 50% of the meeting. Whether that's speaking or they're setting agenda items, it's really imperative to make sure this is the case to assure that the two-way information exchange is equal and that this forum remains really a true member meeting and not an educational opportunity for the health plan or not a time for promotion. So 50% is what we usually keep as a rule. Next slide, please. Preparing for the meeting can take over a month depending on resources. Since most of us are really working with minimal staff resource, we do always solicit help from other staff volunteers about 5 weeks in advance via blast email. Tasks that we delegate to internal staff include items we need help with weeks in advance, as well as the tasks that we need managed on that day. Usually we get 3 or 4 volunteers, and it's an opportunity for some of the staff that maybe don't get to leave the office as much to get out there or to learn about a new aspect of the health plan. So typically we have 3 or 4 volunteers raise their hand, and we delegate tasks to them via email along with instructions and a timeline for preparation. This includes help with the mailing and recruitment phone calls, which are really the most time-consuming component for us for planning these member meetings. We train internal meeting volunteers how to carry out their responsibility as needed. There's not really one big training, but we send that initial instruction and then anything we need to do for follow-up. And the member meeting coordinator, who again only devotes 50% of their time to these meetings, creates all the invitations, the flyers, the handouts for each meeting. And it's not so bad because we have our original templates and it's really just changing the content as needed. She will send those flyers or agenda items to marketing if there needs to be some kind of edits done. And we do print the flyers in-house along with our handouts, the agenda, the invitations. We don't use a vendor. I know that was a question asked to the speakers last week's webinar, so we don't use a printing vendor for this member meeting. The coordinator also drafts the content of the agenda, like I mentioned, as well as a facilitator script, using the input that was received from members during the phone calls, and also anything that internal stakeholders from different departments mentioned they would like us to discuss. If we're using a new host facility, we always make sure to visit the location to make sure that it's truly accessible. And that's important because sometimes you'll call somewhere and they'll say, yes, we're ADA, certified, but you get there and the ramp's broken or, a variety of things could go wrong that maybe that staff didn't know about. So it's definitely a great thing to visit the site. It also helps to build a relationship with that facility staff. Again, you can leverage their support for recruiting. And in that visit, we also make sure that the room is suitable to host the number of confirmed attendees. We set up transportation the week before the meeting with our transportation vendors, and we buy the refreshments the day before the meeting. The last thing that we do the day before the meeting, and really one of the most important things, is a follow-up confirmation call to each and every participant that said they would come, and even those that said, I'm on the fence, I might come. So we give them a call, make sure they understand or don't have any questions about the member meeting, make sure they're bringing somebody or they're not. So we've accounted for all the folks that will be there. Tell them which transportation vendor's coming, what time. And it's really kind of a good reminder for both parties, and also, life happens, so a lot of us forget what we have the next day. So it really assures that they do, in fact, attend. Next slide. Okay. So on the day of the meeting, we usually arrive about 2 hours prior to start time, and that's to set up the room in a comfortable way, something that's conducive for socializing and has enough space for all assistive devices to be used. We set up refreshments and hang up directive signs in the front entrance of the building, putting up arrows as to where the meeting location will be held, and also leading up to the room so that consumers can easily find the room and don't get lost and frustrated before the meeting even begins. We set up a reception table where members check in. We hand out a name tag with their first name, and we have them sign a consent form to authorize the use of photographs and recorded notes of the discussion that occurred during our member meetings. And prior to the member meeting, copies of the member authorization form are printed out for members to read and sign. Staff are trained to explain the form in simple and straightforward language. And most importantly, we make sure that they know to stress to all of the members that anything they say in this meeting will in no way affect the care that they receive from CCA nor their contracted providers. So we really want to assure that they're giving us honest feedback and they're not feeling timid or shy, that anything they say in the meeting will affect the care they receive. And members are not required to sign this consent form. If they choose not to, we assure that the photos or any record is not used of that individual. The reason we take such detailed notes of what is said at the meeting is for accuracy. We want to make sure all of the feedback is reported in a way that the member intended, with no room for subjective interpretation by the coordinator or any of us, and it's really what the member wanted us to hear. We use the photos in the newsletter. We send them out internally in emails to kind of promote the member meetings. We put them on our webpage and other spaces as a means of promotion. The photos really capture the fun and social environment of these gatherings, and ideally we can use those to assist with recruitment in the future. After the facilitator is front and present to begin the meeting, the other staff are all set to do their assigned tasks, which includes taking detailed notes, passing out flyers during the meeting and handouts, attending to member needs if somebody needs water or they might need to use the restroom and need assistance, someone's there to do that. And also taking photos, like I mentioned, to document the event. Once the member meeting is over, there's a staff person assigned to coordinate the pickup transportation for members. And during that time, we also leave, again, about 10 minutes for the members to socialize or meet with staff if they have any follow-up information or details that they wanted to discuss from the meeting that day. Next slide. Okay. So this is my favorite part, is really the documentation and follow-up and why member meetings are so powerful and can really be used as a tool for improving quality. So after the meeting finishes, the member meeting coordinator organizes these meeting notes that were taken and puts them in a report format. Any complaints that we heard at the meeting are documented and sent immediately to the Member Services Complaints Coordinator for follow-up. The full report, however, is distributed to members of a cross-functional, what we call debriefing committee. So this debriefing committee is a group comprised of decision-making representatives from CCA, from all of the relevant departments. So we usually have somebody from operations, we have someone from provider networks, from quality, someone from our member services staff, and the SVP of medical affairs as well, and other stakeholders as necessary depending on the meeting. And this group meets after each meeting to review the report that the coordinator produced, and they categorize the information and the feedback that was received there at that meeting. And they assign any follow-up action to the appropriate personnel and also discuss the trends seen in the feedback. The categories that we use to track the initial trends include the first bucket we use is a policy issue if it relates to one of our policies. If it relates to a primary care site, so a complaint about a facility or feedback about a facility. The next bucket is primary care team. We have something for provider networks, and that goes for all of our third-party entities, and also member services. So we put all the feedback into those buckets. And after that committee meets, I'll talk about what we do with that report in a second, but before that, the member meeting coordinator is sure to follow up with the participants. That might be via letter or via phone call to inform them of what did or did not happen with their respective feedback. And also the reason why, which is really important. And that's how we initially close that feedback loop that Bill mentioned earlier. So each of these individual member meeting reports that we have is consolidated into a larger annual report. And all of the feedback is summarized, and the larger report is shared with the Management Quality Committee as well as the Quality Committee of the Board. And they really look at the higher level trends and review all of the feedback received from that year. The follow-up and accountability of information from member meetings is really what makes this process so meaningful and so successful for us. From this review process, CCA has been able to identify gaps or problems before they became more substantial. As a result, member meetings have directly allowed for us to find resolution leading to better quality of care for our members. And I'm going to give you a few examples here. The first feedback that we ever got during the member meeting, I think it was back in 2004 or 5, is that we didn't have a newsletter, and they didn't necessarily request a newsletter directly, but they did ask for updates about CCA, about the health plan. They wanted to know about, what was happening with healthcare across the state, and also about upcoming opportunities. So we created a quarterly newsletter based on that feedback. We now produce it in 5 different languages, and we also post it online. And from our newsletter, occasionally we'll get phone calls of, hey, I saw a picture of this walking event. It looked like so much fun. When can I sign up for the next one? So you can really leverage that newsletter as a tool for recruitment, which was a direct result of member feedback. And then we also have a more informed consumer base, which is certainly mutually beneficial. At another meeting, we had a really high concentration of members who spoke Cape Verdean Creole. They let us know that their front desk receptionist at the primary care site that they went to did not speak their language, and it made it really difficult to make an appointment, especially for those who did not have, a familiar stance on how to use the language line. So we worked with that primary care site, who was also thrilled to get this feedback, to find a bilingual receptionist so that the 50 consumers that we served in that area could make appointments with their doctor. And we didn't quantify these savings or the cost savings, but just imagine if 50 of your members, all with complex care needs, weren't seeing a doctor as they needed to see the doctor. I mean, I'm sure it's a very large number, but it's really just an example of how CCA partners with our primary care sites to address issues important to our shared member population. And again, this was all a direct result of member input from that member meeting. And the third example that I thought of was there's been multiple instances where our members are complaining about a contracted entity at a member meeting. So no one wants to talk about anything else. They just want to talk about this one specific service provider. So we follow that feedback very carefully, and at a certain point, we'll work with the vendor on a corrective action plan based on the member feedback. At times, we've even had to drop contractual agreements because of member feedback and because they weren't working with us. So this almost acts as an early warning sign. I mean, eventually we probably would have figured out that that vendor was not adequate or meeting expectations. But the members were really our early alarm, and they realized it well before the data was going to tell us that. So the member input is certainly a factor in how we manage our service providers, as the member meetings allow us to flesh out details of poor customer service or repeated concerns that truly affect the care they receive and therefore the quality of life. And to close this feedback loop, we inform our members of any further steps being taken to address issues raised at the meeting. When there's final resolution or a new practice in place, again, we do this. Closing that feedback loop really provides a crucial element of accountability and allows for us to build trust with our members. It demonstrates that their voice was heard and that productive changes have been made as a result. This process really instills a sense of purpose and empowerment that positively correlates to member satisfaction and ideally to increased engagement with CCA going forward. The transformative power of consumer engagement continues to grow stronger with every member meeting that we host, and as we work collectively with our consumers towards ongoing and sustainable improvements and the care that's delivered and experienced by them. So that's how we close the feedback loop, and that's all I have for today. I hope that you found something useful to take home, whether it was about planning or preparing or hosting member meetings, as it relates to improving the quality of service that you all provide. So thank you, and I'll hand the microphone back to Jessica.
Thank you, Courtney. Thank you, William and Courtney, both for sharing your knowledge and experiences on consumer engagement and member meetings. And now for all participants, I invite for you guys to think about your current environment and the consumer engagement and answer a couple poll questions that we have. The first one being, which of the following incentives would you suggest and or provide to members in order to increase participation in member meetings? And we have 6 options here. We have meals and refreshment, educational opportunity, financial stipend or gift card, dependent care services or reimbursement, transportation services or reimbursement, socialization, contribution to plan improvement or similar, and select all that apply. I'll give you just a moment. All right, and wonderful. And Bill, would you like to make a couple comments on the results that you see?
Yeah, absolutely. Of course, high on the list, I think it's very common to have meals and refreshments, but it's really nice to see kind of that folks are considering all of these because there's, a ton of incentives that are possible. We have a whole list of them on our website, on our toolkit, under our checklist for diversity incentives and barriers to participation, so check that out. But this is definitely quite representative of what we found in our research, and it's good that everyone's considering all the different options that are out there to incentivize folks to these meetings.
Okay, great. Thank you so much. And now if you take a look at your screen again, we've moved on to our second poll question, and this states, which of the following benefits of member meetings do you think contribute to improving care delivery? Do you feel that general consumer feedback about the delivery system is important? What about population-specific feedback or members who are seniors, adults with disabilities, or maybe part of the LGBT community. Maybe partnering with community-based organizations, providers, and or advocates, health, educational opportunities, or possibly you don't see any benefits with executing member meetings. And go ahead and select all that apply, just like the previous poll. Wonderful. Bill, would you like to make any comments?
Well, I love the fact that it says 0% that they don't see any benefits to member meetings, of course. That's fantastic. But, you know, again, we find that the feedback is generally the most important part, and a lot of times educational opportunities are also important, but they seem to usually fall secondary to making sure that they're getting feedback from consumers, both, you know, from a general perspective as well as specific to a particular population, so they can really learn about that community. And, of course, it really is an excellent way to partner with your community-based organizations, providers, and advocates, because these are the folks that are in, you know, on the ground, you know, doing the work, obviously, right there in the community, and the plan is oftentimes not quite as embedded in the community as all of these folks are. So, of course, 83.5% see that as a benefit to help the health plan sort of infuse itself into the community. So, yeah, it's really wonderful to see.
Wonderful. And our last question that we have is just sort of a full environmental scan of seeing what type of organization you represent, whether you're from a health plan, an advocacy organization, a provider, possibly working for the state, a consultant. And if you don't see an option that applies to you, go ahead and select other, and just go ahead and specify in the group chat or in the Q&A what organization you do represent. Great. Bill, would you like to comment on the variety of individuals that we have?
Again, great to see a good mix of folks on this webinar, similar to our last webinar last week on consumer advisory committee meetings. And, of course, you know, the great majority are the plans that are endeavoring to engage these consumers, but there's never a shortage of advocates and providers and, you know, others, policymakers and consultants at the table. So, again, we appreciate everybody coming together to, you know, be part of the solution for, you know, improving delivery systems and engaging consumers, you know, in that effort.
Great, thank you. All right, in the remaining time that we have, let's turn our attention over to a few Q&A that we've received. And again, as a reminder, if you do have a question, please use the AT&T operator or use the Q&A field that's presented on your platform. Operator, at this time, would you remind our participants how to ask a question over the phone line?
Of course. Ladies and gentlemen, if you wish to ask a question, please press *0. You will hear a tone, and an operator will gather your name and further instruct you. If an operator has already collected your name, please press *1 at this time.
Wonderful. Thank you. Our first question that has come in is referencing, do you have a dedicated staff person making these phone calls to members to remind them of the meeting and also to confirm that they're attending, and possibly the follow-up thereafter to ensure that their feedback is being received? Courtney, would you like to answer that?
Sure. So like I said, we have one person, and that is her title. 50% of her job is to coordinate the member meetings. But we're now, the health department, or health education department is now a team of 6 people. And usually she'll identify 2 or 3 of us to split up those phone calls, depending on what language they're in. We all speak different languages, so depending on the member meeting. But there usually are about 3 or 4 of us tackling 300 phone calls, and that does include the first round of phone calls, the second round to folks that we missed, and then finally that confirmation phone call. So it is relatively time-consuming, but it's also, you know, the best way that we've found to get members to our meetings.
Wonderful, thank you. And, you know, we've had a couple questions about individuals seeing the invitation and the flyers that are being sent, or possibly even the authorization form. Bill, do you have a reference for them? Bill, are you still with us?
Oh, sorry about that. I did have myself on mute as as I'm supposed to be when I'm not speaking, but now I'm speaking. So thanks again for that question. And yes, we do have that. Those samples are available on our website. We knew that they would be, possibly interesting to a lot of folks participating today. So that's something that we did create as part of our toolkit. So please go to communitycatalyst.org/meaningful-consumer-engagement. Look for the member meetings section, and then within that interactive web page, you'll see some of the different samples, both the authorization form as well as the sample invitation letter and the sample flyer.
Okay, wonderful. Thank you. And Courtney, a question that's come in for you is, and Bill possibly thereafter, is for the town halls type style meetings, who facilitates the meetings, and do you employ a facilitator if that's external or internal within your organization?
So the facilitator that we usually use, because, like I said, this department has grown so exponentially, we started out with having, the woman who's now the director was our original facilitator for every single meeting. And again, if we don't have somebody that speaks the language, then we'll partner with the meeting facility to really co-facilitate. But it typically is the member meeting coordinator, again, that person that devotes 50% of her time to the meetings, is also the facilitator. And, she went to a couple of trainings, but she doesn't have a background necessarily in facilitation, but has really become an expert over the past 5 or 6 years that she's been running them. So currently we have 2 full-time facilitators, and then we'll contract again with a partner organization if we need to do that.
Great. And what's the frequency of the meetings?
Usually we have a meeting about once a month. That was last year. Actually, I'm sorry, it's more than that. So I think we had about 20 meetings total last year, and we are increasing that every year, especially as the department grows. But when we first started out, I want to say it was every other month to manage one of these meetings.
Okay, great. Thank you. And can you talk a little bit about the products that you produce after the meeting, the recordings, how are they saved, where are they being saved, the reports that are produced, and what kind of quality measures you use for the providers or the feedback?
Sure. So we, right up front, we save them. We have this kind of template where we have, it kind of looks like a focus group breakdown where you have actual quotes from members, and then you have a different section that summarizes what was the general feeling, what were the main topics that were spoken about. We do kind of add a little note if, someone had a really strong feeling behind their feedback, because we want to make sure that's replicated in the report. So me saying I'm really angry about services is different than me standing up yelling, I'm really angry about the service. So we make sure to note that. And then really when we bring the mini report to the debriefing committee, each of the comments or lines of feedback is categorized by those 5 or 6 buckets that I read. And that's when we put all of those into one big consolidated report. And I want to say the board committee reviews them quarterly. I don't want to be quoted on that, but they put those into bigger buckets. So they use buckets that CMS uses, both for complaints and they have a whole algorithm behind the method of really categorizing the feedback. But they do get that initial follow-up from the member meeting coordinator, the members do, after the debriefing committee. And then they'll get a second round of follow-up if something bigger actually changes, which comes from the management committees. If they make any further recommendations based on trends that they're seeing from that larger consolidated report, we do a second round of feedback to really close the loop up.
And specifically, do these responses from the meetings get used as part of the quality measurements for your providers?
So the responses from, can you say that again?
Do the responses from your member meetings get used as part of any quality measurements for your providers?
For our providers, I can't speak to that. I know our provider network department person does have, they have their own tactic of following up when we bucket those complaints or feedback. When we bucket them provider networks, that department has their own methodology of following up with the third-party vendor, and they work with our compliance department to really decide if an action plan is needed, if there's enough complaints seen or enough pieces of feedback that are saying this vendor is not meeting our expectations. They work together to follow up with that provider. So it certainly is. I don't know if it's reported to CMS that far, But internally, that is certainly something that we use kind of on the provider network report card that we give to each of our vendors.
Okay, great. Our next round of questions that have come in are regarding the giving feedback back to individual members, and you talked about phone calls. Can you describe maybe the type of feedback or the types of situations that you guys encounter when processing good and bad feedback from members, sort of where it goes and what you do with it?
Sure. So with the feedback, for example, if we're not going to be able to use it because of a lack of resources, or, if it's someone in a rural area who wanted, access to a certain thing that's just not going to be possible, then we do call them and explain that there's a lack of resources. In the future, if we have more members in that area, we might be able to devote more resources, and we try and find some kind of a resolution, something that can at least satisfy whatever that request was. And generally speaking, they're very understanding. They know, we're a nonprofit. They know that we are serving dual eligibles in the state. So relatively speaking, they've been very understanding of when we can't act on that feedback. But we do keep that on a separate spreadsheet of feedback that we have not taken action on for whatever reason. And we do review that from time to time to say, okay, this year we've grown more. Is there anything on this list that we can address that we weren't able to address last year? And for positive feedback, sometimes it's in a written letter. Sometimes our member meeting coordinator calls and says, it's really great that you told us that this provider didn't speak this language. We've worked with them, and as a result, they've either employed the language line or they've hired another staff. So a lot of times that will go written because it is a very positive change. And also it might even be published in the newsletter to really give a sense of purpose to what that feedback was and show the other members that the feedback really was utilized and it did make effective change within the organization.
Wonderful. Wonderful. Thank you. And we've just got a minute or two left within this presentation. Operator, do we have any questions come through the telephone line?
No one's queued up yet. Please, if you'd like to ask a question, please press *0. If an operator has already collected your name, please press *1.
Thank you. All right. For the last couple questions that we have, Courtney, from what you can tell, what is the overall participant return from those who registered versus those who have attended the meeting?
So is that in regards to the folks that confirmed and those that actually show up the day of, or from year to year who's coming back to the meeting?
I believe it's the individuals who have confirmed that they're going to come to a meeting versus those who actually attend.
I gotcha. So typically it's pretty high. I think, like I said, that follow-up phone call the day before really helps that out a lot. But I would say, generally speaking, if we've confirmed 40 people, we assume that 5 are not going to show up. But then on the other side of things, sometimes a member did not tell us a caregiver was coming or a family member. So I don't want to say, it's 90%, but I would venture to guess that 70% of the folks that confirmed the day before actually do show up. And that's, again, because of the phone call and also because we offer that transportation. So the transportation service person is going to wait at their door no matter what at the time of the meeting. So it makes it, I think, a lot easier for people to make that decision to step out of their house and attend. So I want to guess it's 70 or 75%, but I don't know for sure.
Okay, wonderful. Great. Well, I really, really appreciate everyone's time. I'd like to thank our speakers and everyone for their participation. We are going to move on now, and we'd like you to know that we have a Meaningful Consumer webinar series and another webinar on training consumers. This webinar will walk through the approaches and content necessary for successful onboarding and consumers to advisory committees and or governing boards. So look for that this summer. Okay. At this time, I'd like to remind you that if you have any questions or comments, please email rick@lewin.com, which is RIC@lewin.com. You can reach out to obtain the speakers' email addresses if you have additional questions. You can also find their email addresses on resourcesforintegratedcare.com within the speaker bios. I'd like for you to take just a couple minutes to complete our post-webinar survey. It will pop up in the window at the conclusion of the webinar. Have a wonderful afternoon, and this concludes the webinar.
Thank you for using AT&T teleconference. This does conclude your call. You may now disconnect. Speakers, if you'd like to go back to your main room, please remain on the line.